less than 1.6 kilos is not established. And for dosing for infants less than 29 weeks, okay, very important, it's based on extrapolation. So a lot of industry are now doing this for various products coming out. So efficacy is derived as a surrogate, okay, based on exposures to the virus. And if you meet that threshold, then they're saying it's efficacious. There's limited information in preterms less than 29 weeks and less than 8 weeks gestation. The efficacy for CHD and BPD is not a placebo-controlled trial. Again, it's extrapolated and showing that it does meet the criteria of the certain percentage of exposure to Nirsevimab. So they're saying it is effective. In the first season, all Nirsevimab data is based on first season. The second season data is all extrapolated for BPD and CHD, primarily looking at safety, not a reduction in hospitalization, okay? And there's very limited data for all of these other conditions that we just talked about compared to Palivizumab, for very little data. The only data is from the MUSIC trial of 100 immunocompromised patients that Joseph Domachowski did from the United States, showing over 2 seasons no serious adverse events, and in fact it was useful up to 1 year post-prophylaxis. So let's do, for fun's sake, a head-to-head comparison, so it'll all make you wake up. So Palivizumab versus Nirsevimab. So we have robust efficacy data for the first and second season in Palivizumab. Nirsevimab limited to the first season only because that was what the randomized controlled trials did. For the second season, it's extrapolated data. In the subpopulations, again, very good for Palivizumab, robust also for Nirsevimab between 29 and 35 weeks and greater than 35 weeks. Very limited for those less than 29 weeks. BPD, CHD, robust for Palivizumab, placebo-controlled trial, extrapolated efficacy for Nirsevimab. Down syndrome, very strong for Palivizumab, very limited data or no data for Nirsevimab. Immunodeficiency and cystic fibrosis, good case control and prospective data, case series for immunocompromised with Nirsevimab. Pulmonary hyperplasia, airway stenosis, esophageal atresia, metabolic and neuromuscular disease. We have an open label phase 2 study from Japan and very good observational prospective data. None for Nirsevimab. Availability, supplies freely for Palivizumab, prioritized for Nirsevimab. So if you decide to use it in all your infants at the same time, the likelihood is that you may receive product. If you decide to only give it for a small population, industry will say, well, we'll think about you, you're second grade, you're not first class because you're not giving it to everyone, so we may not have enough product for you. So think very carefully about that.
We have limited data.
Yeah.
In most of the categories.
Yeah. Yeah.
We give it to the high risk.
Where? In Nirsevimab? Yeah, that's the problem. So this is what I'm trying to show you. So be very careful. You know, there's more data going to be emerging over, and then cost effectiveness, okay? And safety data, don't worry. We've got 25 years, we've only 2 years on this side. So the issue is, I think everyone needs to sit around a table, certainly in Saudi, and come to an agreement. Should you have a staged approach where you consider Palivizumab for the high-risk population group for the moment, and whether you consider the Nirsevimab for the others, provided you will get the product because you're not going to use it in all of the population. right?
I'm still ready to go down.
You got it. And so do a staged in program, and as you get more evidence, then eventually you can use the monoclonal antibody. And just to let you know, we're talking about Nirsevimab for the 26-27 season. You're going to have Nirsevimab. Okay? Nirsevimab is out. The efficacy data is equal to Nirsevimab. It comes from Merck, and it's exactly similar to Nirsevimab. The joy of Nirsevimab is it's not weight banded. So for less than 5 kilos, greater than 5, all this craziness that you do with Nirsevimab, for Nirsevimab, it's one shot for everybody. Okay? So we are going to have an RSV pre-vaccine for mothers, and we've got so many monoclonal antibodies coming into play as the world starts evolving. So hopefully all of these strategies will reduce the burden of disease in all our countries, not only high income where majority of these studies have occurred, but also the low income countries. So I hope I've shown you in summary that preterm infants, those with BPD and hemodynamically significant congenital heart disease, have a very complicated course if they develop RSV infection and entail significant morbidity. It should also be considered for children with Down syndrome, neuromuscular disorders, CF, and immunocompromised. And I'm glad to see, in a way, we're working towards position statements across the world that are fairly uniform, and they do exist for Palivizumab. And we've learned from this that perhaps they should also be applied to all the new RSV preventives that are coming on the market. Okay? I'm going to stop and see if you have any questions to ask after all of that.